So our last presentation before coffee or tea is from Angela Kelly, and it is about an update on the project looking at patient outcomes in Papua New Guinea. So thanks very much. Angela's from the University of New South Wales.
Thanks very much for having me here today. Unfortunately, with COVID, means I'm living in Australia. I've had to give up my status in PNG, living there for 14 years. But it also means that my colleagues in PNG who would ideally present this today aren't here. So I'd like to thank them. And of course, I want to take claim for anything that we say is good, and we'll blame our collaborators like Steve and Ben and Guy and others, Suman, if we say anything that's wrong, because they've clearly not taught us qualitative researchers adequately enough. But before I do that, I do want to thank Greg for a nice introduction to the importance of qualitative research. Yes, things are not always used as they're meant to. We've learnt that from HIV with condoms. But also that we are also working with Philip Decross from Burnett as well on some other really important qualitative work around zoonotic TB. And with the borders opening, we're very happy that we're going to start some more field work for that next week. But we've got an amazing group of collaborations for this project. It's really exciting. This is being led co-joint by the IMR, the PNG Institute of Medical Research, and also the Kirby Institute. And no doubt we need to thank the provincial health authorities from Western Province, who without their support and guidance, we wouldn't be there. This is an NHMRC study that's entirely qualitative. So again, thanks to NHMRC for your wisdom. So the study aim was to do qualitative research to examine the context, socio-cultural context of TB in PNG, including issues around TB diagnostics, prevention and care in the South Fly district of Western Province. Unfortunately, we had originally decided to include NCD at the time we applied, but with COVID last year, Guy Marks very wisely said to us, just stop and just focus on the South Fly. So I was very grateful for Guy for giving us that wisdom to change our NHMRC grant. And the overall aim of this is to, improve the outcomes of people in their communities and the communities as a whole by building public health solutions that are based on the realities of people's lives. So here, this is the Western Province. We worked in the South Fly district, which is down here on the bottom. We undertook field work in 3 of the local level governments. We were in Daru Urban LLG, which is the island, which most of you probably know about. We also went to the mainland, to Oriombo Bituri Rural LLG and to Kiwai LLG. So that's quite an extensive bit of work. So whilst most of the work and TB treatment is on Daru Island itself, we did go and speak to communities and leaders and religious leaders and nurses, etc., in the mainland, because I think when we talk about decentralisation of services, this is really important. Unfortunately, Daru Island is a very small place and it cannot keep expanding as much as the Chinese would like it to, with their plans to cement it. Mind you, I wouldn't mind some of that cement there on those mangroves. So we did in-depth interviews, we did focus group discussions, we did participant observation, and the one method that is still pending is to do some participatory workshops using photo voice, so where the communities can describe their own issues in their own words. You can see we've got quite a lot of data. You'll see most qualitative researchers have 20, 30, 40 participants. We've done 128 semi-structured interviews with a different variety of people to really try to understand the spectrum of TB rather than only one component. It does make it hard sometimes to kind of narrow down into one particular issue, but we really wanted to get a sense of the entire issues around the TB response in this area. In addition to the in-depth interviews, semi-structured interviews, we've done focus group discussions. And again, you can see here, we've done, I can't remember how, we've got 85 participants in 10 or 11, whatever, focus groups. So quite a variety. Some of the groups in PNG is highly gendered. So some of the groups are gender specific, others were mixed. But because TB is not a highly, even though we know that men have TB more often than women, it's not highly gendered in the way that much of our issues that we do at the IMR is with sexual and reproductive health. So it was okay to mix participants. So having spent months on end transcribing and translating and now coding the extensive data set, we've just started to re-examine the data again a little bit more and thinking about what it's trying to tell us. And not surprising that the data is really rich. We're gleaning insights into significant issues such as how the DART sites operate, issues of stigma and discrimination and how they've changed over time, issues around care, gender, pathways to diagnosis and treatment, adherence and resilience, as well as what we're referring to as the TB riskscapes, the structural as well as the socio-economic drivers that sustain the spread of TB and the reinfection of TB, despite the money being spent on treatment and diagnostic technologies. For the people in Daru, these were really important issues, and it frustrated many that these were not being looked at. But today, in no small part because of the session we've been put in, we tried to rethink about what we wanted to present to you. And so today we decided to look at a relatively new model of test and treat that's been introduced into PNG and to Daru in particular. But it's no mean rolled out everywhere and it's not looking the same. So we want to talk about the localisation of global guidelines for the prevention treatment of children in less than 5 years of age category. It's also timely as only 1 to 2 weeks ago, the National TB Technical Working Group provided an update on WHO guidelines. And as a result, PNG itself will also be updating its TPT guidelines, which, as I said, has not been widely used in PNG. They're getting dust on the shelves. Only 2 sites in PNG are doing preventative therapy, as I understand, Port Moresby General Hospital, which has got a very different model to Daru. So today we want to tell you the story of why some parents are choosing to engage in this program and why others aren't. The national support for preventative therapy in children was in its infancy when we first started. At the time, the treatment was 6 months, but then had transitioned to 3. Despite this innovation on the island, parents and caregivers sometimes spoke of having TB in their homes, sometimes for short periods of time, sometimes only 2 nights, where others had much more extended exposure, sometimes months without the person seeking treatment. The index cases varied, but were often men, uncles and grandfathers of the children who had come from the mainland to seek treatment, highlighting the gendered nature of TB. Becoming more recently aware that TB was airborne and not transmitted by blood, people were starting to assess their own living conditions and those of Daru more generally, and they could understand the risk, especially as it was explained to them thoroughly through the house contact tracing activities. The role of the staff in explaining and answering the questions was acknowledged as one of the really important deciding factors for why parents chose to accept preventative therapy for their children in the absence of disease. Health-seeking behaviour in PNG is such that even when people are ill, it takes a very long time to seek medical care and treatment. The idea then to treat an infection that you cannot see or read on the body as it manifests through signs and symptoms on the skin is radically out of sync with how treatment and management of illness works in Papua New Guinea. Preventative therapy thus is a medical technology that not only treats an infection for which you cannot see, but it totally disrupts traditional notions of health and illness as they're commonly imagined in PNG today. Here I'm going to just show you briefly what, can you get the volume, sorry? Does the volume work? So this is one of the staff working in one of the homes. In this home, we found 19 contacts that had to be referred to the clinic. This is being done in the local Kiwi language, which is really important. And here the gentleman in the striped shirt at the back is the grandfather of these children, and he had XDR-TB, and as a result of the treatment at the time has hearing impairment. But actually he was now being contact traced because his own granddaughter had come from the mainland. And so from this contact tracing, you can see the children sitting there under the house. 19 people were referred. That's not insignificant. Preventative therapy in children places responsibility, though, on an individual. And in the case of paediatric interventions, it places it very much on the caregivers. In Daru, this is important because it's not always the parents who are in the position to choose treatment. And as we come to understand, and we'll show you, it's also not always the parents who are in the position to cease the treatment. This is an issue we come back to. It's not so much an issue of the program, but the cultural context in which the program is operating. Again, the localisation of globalised policies. The narratives the caregivers gave as to why they agreed to put these type of children sitting there who were healthy on anti-TB treatment were otherwise were common and not what you would unexpect. Rabian and Melis are two of the couples that we sat with, and they lived in a crowded house. And because Ben Marai wanted to know about the structural issues, we kept asking people, tell me about your house. How many windows do you have? How many people live there? They said to me, it's not crowded because of how many people sleep here. It's not about the number. It wasn't about whether or not you can accommodate 20, 30 or 40 people in your home. Houses are crowded, she said, only when people have to start putting tents up in the yard or they're sleeping on the veranda. That's crowded. But they lived in a house that wasn't crowded. They were fortunate enough to have a room for themselves and their 4 children. In the other room lived the brother and his wife and all of their children. This story resonates with many of the different families. For them, they already had 8 people they could easily identify in their family who had had TB, including their own 11-year-old daughter who was infected, who was diagnosed when she was 1. So TB is no stranger to these people. They had in the last few years come to understand how TB was transmitted because of an increase in community awareness around TB that had been recently developed on the island. Their daughter, Mary, it was her uncle that had come to stay with them and had been diagnosed with TB, MDR TB, several weeks after coming from the mainland. Having been told about the treatment, both of Mary's parents discussed the risks. And besides having already endured a child with TB several months in hospital, they agreed to put little Mary on medicine. It was easier to having to face the possibility of a future they said that could include a disability because they understood about her immune system and the risk for TB meningitis, or worse, they talked about not wanting to cry. They didn't want to cry over her body, having lost her from TB. So in their words, they said to us, we agreed, it's okay, let's try and fight this, even if fighting this in Daru means putting our daughter on treatment. For this family, the choice wasn't only driven by a desire to prevent disease in their own daughter's body. They took a wider civic duty to prevent TB in their own community. But people discouraged them quite openly. Even Rabian's boss told them not to go onto the program because children on the island were being used as guinea pigs. Still, as parents, they were committed to take the treatment. Even when Rabians and Melis may falter and forget little Mary's medicine, she would be quick to remind them, Mummy, I didn't drink my medicine. And equally quick to remind her father when he returned home from work, Daddy, I took my medicine today. As a social researcher, the fact that Rabian was a hygiene officer, or as a cleaner as we once called them, was not lost on me. He was accustomed to removing dirt, matter out of place. That's what he was paid for. TB for him was an infection in his daughter that was certainly out of place. At the time of the work, we did TB, I still want to say IPT because I come from an HIV background, so I'm still getting my head around TBT. It was not available in other parts of the South Fly, and this is really important because it helped make other people's decisions to consent to treatment. So not only is TPT not available on the mainland, standard TB treatment is also not available in many of the communities we visited. At least one of the fathers, a 36-year-old father called Felix from the mainland, who consented without his wife's agreement to his 2 children to commence on treatment. Telling us about how he then went about telling his wife, he said she was thrilled. This is good, she said, because in our village, there are no centres. She gave me the same answer as I had come to. She said, this is good. If we go back to the village, who will give us medicines out there? There's no one out there. It's good fortune that we're here, so let's just put her on the medicine. So he viewed his decision from that of his daughters, and he wanted them to know that he had been a strong father, a hard father, and he had made the hard decision to make a treatment choice in the absence of illness. He also speaks to the issues of decentralisation. So even though in Daru, the health outreach work goes to the families, in Port Moresby, the families have to come to the centres, decentralisation is still in its infancy in Daru. So while there's been a relatively high uptake of the program, some 70%, not all guardians have consented, and if they did, not all have continued to treat their children, even if they had already started a treatment. While trying to have children take medicine that was yuck, as one little girl told me, it was the reported side effects, the treatment toxicity that families described witnessing in their children after commencing treatment, even only some 2 or 3 days, that caused most concern and was the primary reason for ceasing preventative therapy. The side effects included bodily changes such as rashes, sores, diarrhea, losing weight, and lethargy. In other circumstances, it was simply not having a multi-month refill and having travelled to the mainland and not being able to return in time before the treatment had finished. These side effects matter, though, when families treat an invisible infection for which there are no symptoms. Preventative therapy causing illness seems contradictory in people's imaginations, but there are also other reasons that we want to highlight for why preventative therapy was stopped. And that's the issue of consent, and something we can only briefly talk on. I wanted to share you the story of Mari. She's a Highlands woman who had been bride priced, and she had migrated to work on Daru Island for work. She was a healthcare worker, so she was not uneducated. Living in a house where a man working at the hospital was diagnosed with TB, she had agreed to have her daughter start preventative therapy. As a healthcare worker, she understood the need to prevent an illness and agreed readily to start treatment. However, a few days into the treatment, Mari, like many caregivers, noticed how the treatment was changing her daughter's body and that of others. In Mari's case, her daughter, usually a light-skinned girl, turned black, as she said, as black as a bougainvillean. Her daughter also came out in rashes. For those of you who know PNG and the beautiful shades we have, you understand. Her daughter came out with rashes and sores all over her head. Talking to her husband on the phone, she explained the situation. She hadn't yet told him, who was working remote in an oil plantation, that she had needed to start treatment to treat TB, sleeping TB as they called it. He didn't know anything about sleeping TB. The father of Maggie's daughter, Mari's daughter, her husband, demanded that she be withdrawn immediately. Without a proper investigation to show she has TB, the daughter's father's decision stood. "Stop it now," he said. While he was away working on the mine, he had no control at one level, but on another level, as the father of the daughter, he has all control. And it's his wife's obligation to listen. While mothers may play significant roles in the daily lives of their children, others often have greater rights over their children's welfare, and in this case, the father. In other families we spoke to, it was the grandmother who went across against the decision of her grandson's parents, or conversely, a grandmother had initiated treatment without the consent of the mother, who was in the hospital ward with the other child being treated as the Wasmary. So in PNG, care is shared across numerous sites, across numerous adults, and it's important to ensure that consent and responsibility to ongoing treatment is well considered and supported by all. So these qualitative findings, which show these, they're rich and they tell us about what it's meant to work in the TB response and some insights of the new models of test and treat that are available to communities in PNG. But also they show us things that our clinical data can never show us. This type of data plays an important role in guiding the adoption of global preventative guidelines in local contexts. And while our guidelines detail the procedures and the processes to commence and monitor children on therapy, I'm reminded by Mary about the heart of the program. For her, going to the clinic was all about the drawings. You won't find having pencils and paper at the TB clinic as one of your major criteria for preventative therapy for children, but for her it was everything. And so I ask that when we think about our test and treat programs, we keep our children at the centre of those programs. Thanks. you.